said earlier, my name is Menka Amatat, and I'm a practice-based commissioning manager, but I've also been working on Southall Initiative, the Diabetes Project in particular. Working with 6 practices, and it's one of the practice-based commissioning groups, Southall Primary Care Commissioning Group. With me, it's going to be Harpal Rai, who is a diabetic specialist nurse who's been working very closely with us, and one of our practice managers, Jayshree Patel. These aren't the only people that have been working with us, and our team has just been really large. And I'll put up a list later on to show you just how big the teams have been. Just before I start this is the Southall part of the work that we've been doing, but there's a strong link between what we're doing, the care pathway work that Ealing Hospital are working on, and what's going on at Ealing Wide in terms of strategy of working with primary care and redesigning the whole diabetes pathway. Just going to start by talking about the national situation with diabetes and why we looked at diabetes, what's going on in Southall, and what we did in the project and what we're planning to do in the future. So the national situation with diabetes. Diabetes UK estimate that 2.8 million people in the UK have diabetes, and that was at 2009. 16% of those 2.8 million don't even know that they have diabetes. By 2025, it is estimated that there will be over 4 million people with diabetes. But some populations are at higher risk of developing type 2 diabetes than others. And those include South Asian, African, Afro-Caribbean, and Middle Eastern populations, amongst others. It is also thought, or it is also known, that some less affluent and socially excluded people, such as prisoners or refugees or people with learning disabilities or mental health problems, receive poorer quality of care because they just can't access it as well as the others. And diabetics have a higher emergency admission rate than the general population from complications such as coronary heart disease, stroke, peripheral vascular disease, kidney damage and failure, infections and other conditions. In Ealing, as of April 2010, and based on the QOF data, the Quality and Outcomes Framework data, there were 18,878 diabetics in Ealing. In Southall, there were 7,733. That's a huge number of people we're talking about. 29% of Ealing's population live in Southall, but 41% of all the diabetics in Ealing live in Southall. In the 6 practices we were working with in particular, there were 1,413 diabetics, of a shared population of 17,350 total. So the prevalence rate in those 6 practices is a lot higher than all of the other practices. But that could be because of reporting on QOF, and there are a number of reasons that that could be a reason. And we need to look into that a bit further in the future. As we all know, the population in Southall is ethnically diverse. So therefore, many of the populations are at a higher risk of developing diabetes. One of the statistics that really stuck out to us was that over a 5-year period, from 2003 and 4 to 2008 and 9, Ealing's the diabetic emergency admissions rose by 95%. So what did we do in the project? It was led by 2 arms really. There was a PCT project group looking, and they were responsible for providing general oversight of the Southall project, but providing the link between the Ealing-wide developments of diabetes and what is going on at Ealing Hospital end. And all of the other hospitals in the area, Imperial being one of them. Then the actual practices were involved in really good pieces of work. They were split in 2 areas. The practice managers and the receptionists really came together later on in the project, but to think about some of the hands-on issues that they were dealing with on a day-to-day basis. And it was really important to recognise their role, practice managers, practice nurses, receptionists, and diabetes care. On the other side, the strategic overview of the whole project was leadership workshop over a Saturday, which Louise was very much involved in developing, a lot of people who were involved in. And yeah, a lot of patients that came, and I'll talk about that in a moment. They also looked at baseline data, so they looked at all of their cough indicators, and as many of you will know, there are a number of cough indicators for diabetes. And they had clinics in each of the practices where a diabetic specialist nurse went in and was looking at what was going on in the clinic. Was there anything that we could help with there, so that the diabetic specialist nurse could help with? Or was there anything that the PCT could help with? Or was there any advice or learning between the practices that could be shared? So the patient consultation day was on a Saturday. We had two events, one in the morning and one in the afternoon. We had a turnout of 55 diabetic patients and some of their carers from all different backgrounds, which was absolutely fantastic. They loved the day, and they really they wanted us to run another one in 6 months' time so they could feed back and learn what was going on in the next 6 months, in the next year. They really recognised the importance of general practice as a source of advice and information. And these are just some of the issues that came out, but so much came out on that day. It was just an amazing event. The patients wanted more support and encouragement to manage their own condition rather than relying on the healthcare professionals. They wanted us to help them facilitate patient support groups that they could run. And they wanted more education, particularly about medication, about diet, and for the entire family, because as we know, not only the diabetics cook, but their family members cook for them. Foot care and exercising. Jeshri?
I work for the Sunrise Medical Center and the Somerset Family Health Practice. As a group, I am here to present on behalf of our SPG group between 6 practices. And the baseline data as follows. With the help of cough data, we find out that we have very good recordings on BMI, retinal screening, peripheral pulses, neuropathy testing, blood pressure, microalbuminuria testing, EGFR or serum creatine and total cholesterol. But as a group, more improvement is required with regard of HbA1c control. Exceptional reporting was also found very high within some practices that we have data and we are going to produce.
Hi, as I introduced, Leha introduced me earlier, my name is Marple and I work for PCT and I'm based at the hospital. I was asked to participate and go into GP surgeries and make some assessments. And the areas that I covered on those assessments were clinical competencies, effective care planning, effective self-care and governance. And within this, I looked at practice nurse competencies and their requirements, and looked at what patients presented with their HbA1c levels, and also looked at what kind of patient education was provided and delivered for these patients. And if these patients had target blood sugars to aim for, or if they had any goal settings, and if this was negotiated with patients. If patients, within their surgery, if they had handheld records where they could communicate within their own surgeries, as in the GP practice, or if they were being seen by a specialist, or if there was any use of new leaflets, whereby which could support them to self-manage themselves, and especially within the different languages required, if possible.
Next, here are some recommendations for the practices. These are some recommendations which we feel would be helpful to improve our services to our diabetic patients. Recognize the key role of the receptionists, training for receptionists so they can advise patients by providing good basic sound training with regard diabetic clinic. Improve communication during consultation. Encourage patients to bring an interpreter if required. Second, include alert of patient's notes or total alert in the computer that we always notice. Screen about interpreter required. Advise strategy to reach patients to regular DNA. Receptionist group patients for review, opportunistically or where possible we have HCA healthcare system available for our scope review. Next is future plan in 2011, action plan. Training for all the practices staff including receptionists. The second is up-to-date literature in a variety of languages. Third is continue close working with diabetes specialist nurse. Fourth, monthly meeting inside practices means in-house meetings and quarterly meetings of whole group to oversee development, discuss feedback from each other and communicate. Findings to the GP consortium. Last point is that I am just mentioning myself that focus on patient-central practice rather than practitioner-centered practices. Thanks for listening.
Just to finish that off, after obviously our action plan for 2011, there are some recommendations that we actually expanding, hopefully with SASL and the wide strategic developments of that across ED, especially just as in developing the internet to support decision making with diabetes care right across, and continue to gather data and scrutinize performances across SASL, and also scrutinize what's actually has been within the pilot itself and improve each stage of its pathway, whereby we can perhaps screen more people and who we are targeting and how we're actually targeting them, and actually entering all the newly diagnosed diabetics on the database. And because as diabetes is a chronic disorder, it does impact on patients, especially emotionally, and help them to really go through a certain pathway where they can actually gain assistance and help with that. Further, carrying on with care planning, which is a foundation for really helping set goals, achievements, monitoring, reviewing, and also the involvement of multidisciplinary team members, as dietitians, specialists, eye checks, and patient health groups, and improve practice skills at dealing with depression and diabetes. Thank you.
So, acknowledgements. As you can see, there are so many people involved in all aspects of this work. And we've got everybody's name up there, but a special thank you to Diabetes UK Ros Rosenblatt. But I just wanted to just finish off by saying all of the recommendations that are coming out of here are already starting to act on EU-wide. So, for example, the QUIP project about care planning that Yvonne was talking about, we already very much linked into diabetic patients on that. The recommendations from the patients around the education support programs, we've been working with the Right Start education team to think about how we're going to enhance that and improve that to meet the patients' needs, and a number of other things that are going on. But yeah, so diabetes.